ever stared at a lab value and thought, I know this is bad, but I don't totally understand why? You're not alone. Electrolyte imbalances can feel overwhelming, especially when you're trying to connect numbers on a chart to what's actually happening with your patient. So today, we're breaking it down. Simply, clearly, in a way that sticks. By the end, you'll understand what electrolytes are, why they matter, and exactly what to watch for with the 4 most critical imbalances in clinical practice. Let's get into it. First, the foundation. Electrolytes are minerals that carry an electrical charge. They're found in your blood, urine, tissues, and body fluids, and they do a lot. They regulate fluid balance. They help muscles contract, including your heart. They support nerve function, acid-base balance, and cellular communication. In short, your body can't function without them. When levels shift too high or too low, things go wrong, sometimes subtly, sometimes fast. And as a nurse, you're often the first to notice. Let's start with sodium. Normal range, 135 to 145 milliequivalents per liter. Sodium is the primary electrolyte in the extracellular fluid, controlling water movement and blood pressure. Think of it as water's main driver. Where sodium goes, water follows. Hyponatremia means sodium is below 135. Common causes: excessive water intake, heart failure, kidney disease, and SIADH. When sodium drops, water shifts into the cells, causing them to swell. The brain is especially sensitive. Watch for headache, confusion, lethargy, and in severe cases, seizures and coma. Hypernatremia means sodium is above 145, usually from dehydration, low water intake, or diabetes insipidus. Water moves out of the cells, causing irritability, agitation, intense thirst, and in serious cases, altered consciousness and seizures. Your priority: monitor neurostatus, track fluid balance, and never correct sodium too fast. Rapid correction can be as dangerous as the imbalance itself. Now, potassium. Normal range, 3.5 to 5.0 milliequivalents per liter. Potassium is the major intracellular electrolyte, and its most critical role is regulating cardiac muscle excitability. This is the one nurses watch like a hawk. Hypokalemia means potassium is below 3.5, from diarrhea, vomiting, diuretics, or poor intake. Low potassium makes the heart more excitable. On an ECG, flattened or inverted T waves, a prominent U wave, and ST depression. Expect muscle weakness, cramps, fatigue, and decreased bowel sounds, and in severe cases, life-threatening arrhythmias. Hyperkalemia means potassium is above 5.0, common with kidney failure, ACE inhibitors, and tissue breakdown. The heart becomes less responsive, which is equally dangerous. Classic ECG changes: tall, peaked T waves early, then widening QRS, and if untreated, a sine wave leading to cardiac arrest. Patients may also have weakness, numbness, and decreased reflexes. Priority: check potassium before giving digoxin or diuretics, monitor ECGs, and know your facility's critical value protocol. Next, calcium. Normal range, 8.5 to 10.5 milligrams per deciliter. Most people think bones, but in nursing, we focus on ionized calcium, the active form in the blood, because it directly affects nerve and muscle function. Hypocalcemia means calcium is too low, from hypoparathyroidism, vitamin D deficiency, pancreatitis, or blood transfusion. Low calcium makes nerves hypersensitive. Signs: muscle cramps, tingling around the mouth and fingertips, and 2 findings you must know. Kvostek's sign: tap the facial nerve in front of the ear. A positive result is facial twitching. Trousseau's sign: inflate a BP cuff above systolic for 2 to 3 minutes. A positive result is carpal spasm. In severe cases, tetany, laryngospasm, and seizures. Hypercalcemia means calcium is too high, from malignancy, hyperparathyroidism, or prolonged immobility. Here, nerves and muscles are suppressed. Remember, bones, groans, psychic moans, and stones. bone pain, constipation, and abdominal pain, confusion or depression, and kidney stones. ECG may show a shortened QT interval. Consideration: ensure hydration, monitor elderly patients for confusion, and watch for cardiac changes. Last, magnesium. Normal range, 1.5 to 2.5 milliequivalents per liter. Magnesium rarely gets the spotlight, but it's tightly linked to potassium and calcium function and key to neuromuscular transmission. Hypomagnesemia, low magnesium, is common in chronic alcoholism, malnutrition, prolonged diarrhea, and diuretic use. A critical pearl: if hypokalemia won't correct no matter how much potassium you give, check the magnesium. You often need to replete it first to hold on to the potassium. Signs: muscle tremors, irritability, hyperreflexia, and arrhythmias. Hypermagnesemia, high magnesium, is less common but serious, seen in kidney failure and excessive intake from antacids or laxatives. Magnesium acts like a sedative on the nervous system. Too much, and things slow down. Diminished reflexes, bradycardia, hypotension, respiratory depression, and in extreme cases, cardiac arrest. The antidote? Calcium gluconate. Keep it at the bedside for any patient on IV magnesium. All right, let's bring it together. Electrolytes work as a team, and imbalances rarely happen in isolation. That's why your assessment, lab monitoring, and clinical awareness all matter. Quick recap. Sodium controls water movement and brain function. Watch neurostatus. Potassium drives cardiac excitability. Watch the ECG. Calcium affects nerves and muscles. Know Kvostick's and Trousseau's. Magnesium, the unsung regulator. Treat it first if potassium won't correct. Keep calcium gluconate close with IV Mag. You don't have to memorize every detail right away, but understanding why these imbalances happen and what they do to the body makes you a safer, more confident nurse. Keep going. You're building exactly the foundation you need.